An article published this week in AJR looked at the impact of advanced neuroimaging on clinical decision-making in neurooncology. In this study, patients being treated for high-grade glioma underwent advanced neuroimaging for further evaluation of equivocal findings on conventional MRI. The ordering neurooncologists completed surveys both before and after the advanced imaging. Based on the survey responses, their management plans changed from before to after advanced imaging in 44% of care episodes. In addition, the neurooncologists reported that advanced neuroimaging was helpful in 93% of episodes. I'm Andy Rosenkrantz, editor-in-chief of AJR, and I'm here today to discuss the article with its senior and corresponding author, Dr. Melissa Chen, Associate Professor of Radiology at MD Anderson Cancer Center. Dr. Chen, thanks for joining us.
Thanks for having me. Appreciate it.
To start us off, can you give us some background about your neurooncologic imaging practice?
Yeah, so our typical practice at the time when we were doing this study is that when patients are receiving, we have a lot of patients who have follow-up of their treatment after gliomas. And we do what we call our conventional sequences. And it's just our normal, brain MRI with, your FLAIR non-contrast sequence and then your post-contrast sequence. And we reserve some of the more advanced imaging techniques as a problem-solving tool so that we're not doing it on all of our patients just because of the length of the exam and the need to give more contrast than the conventional studies. And so that was the typical practice when we were doing this study.
And in this study, what did the advanced neuroimaging entail?
Our advanced neuroimaging protocol includes 2 perfusion sequences with contrast. So we do a DSC or susceptibility contrast sequence looking at the relative cerebral blood volume of brain tumors. And then we also do a DCE, which is the dynamic contrast enhanced sequence. It's a T1 weighted sequence looking at the capillary permeability of a lesion in question. And we also do MR spectroscopy, and we typically try to do a multivoxel spectroscopy, but sometimes we have to do a single voxel just because of technical reasons. And then if we can do it on one of the scanners, which has our more advanced ASL sequence, we also obtain arterial spin labeling as well.
Can you describe for us the typical management changes that were observed as a result of the advanced neuroimaging?
Yeah, so for many of the patients, a lot of them actually continued management with short-term follow-up, but those that did have changes, they were categorized into 3 main categories. Either there was a change in chemotherapeutic agent. So for most glioblastoma patients, the usual chemotherapeutic agent is temozolomide. And so in those cases, sometimes they were moved to another agent like lomustine. And then some of them were enrolled in a trial. A few of them also underwent surgery or what we call laser interstitial thermal therapy or LIT. So those were some of the different options that the patients underwent in terms of change of management.
You also looked at various factors possibly associated with an impact from advanced neuroimaging. Can you comment further on that?
Yeah, so this study was constrained to what we called high-grade gliomas, and we defined high-grade gliomas by those that had contrast enhancement. So by histologic definition, those were WHO grade 4. But we looked at the differences between IDH wild type grade 4s and IDH mutants. Now, the grade 4 designation doesn't really make a difference. The IDH wild type is obviously the more aggressive tumor, and IDH mutants have better prognosis and are less aggressive. And we didn't find a difference in the change in management, a percentage in change in management between the 2 different groups. Although I will say that our cohort had a significantly more percentage of IDH wild type astrocytomas. So it could have been just the differences or small number as to why we didn't see a difference between the 2 patient populations.
In this study, you described various costs or challenges of advanced neuroimaging. Can you tell us more about these?
We didn't delve too much into the paper because it was sort of beyond the scope of the paper, but our advanced brain tumor imaging program is actually run by a totally different separate set of technologists. They're, I guess, what you would call a super tech. And it's a different team that does the advanced brain tumor imaging protocol. As you can imagine, trying to place voxels over certain lesions and doing spectroscopy, if it's not something that's frequently done by a particular technologist, sometimes it's hard to ensure the quality of those images. So that's just an example of why we have a discrete set of um, technologists that do the advanced brain tumor protocol. So that obviously takes some resources. The protocol itself is actually about twice as long as the normal brain protocol. And so scanner time, room time, those all contribute to increased costs. But the charge for the scan is about the same. I know that there's a CPT code for MR spectroscopy, but it's not frequently reimbursed, and it's not something that we actually charge whenever we do the study.
The unique aspect of the study was the focus on the ordering neurooncologists who were surveyed about how the advanced imaging influenced their practice. Can you share more about the feedback that you received from the neurooncologists, maybe even something beyond what the article reports?
Yeah, so overwhelmingly, all of our neuro-oncologists, it was like over 90% of them felt like the ABTI really helped them in their decision making. In terms of, anecdotally, I will say that oftentimes our neuro-oncologists tell us that patients really want to have another, I guess, tool to be able to help them to make that decision and feel more sure of, whatever the impression that we have, whether or not it's tumor progression versus treatment change. And for brain tumors, it's hard to you can't just do a biopsy. Other areas of the body, you can do FNA guided biopsy and come out with an answer. But in the brain, it's just much more complex to do that. And so, I think one aspect that we weren't able to really delve into of this study is the fact that patients really appreciate having additional information to make those decisions. And I think that helps also with the oncologist to guide them towards what the next steps would be based on that. And sometimes patients have a hard time believing that their tumor may be progressing and really want to hold on to treatment change. And so, there may be different biases that the patient or the oncologist has. And this gives them another key point of information that is somewhat more objective.
Yeah, it's helpful to hear as well how this also comes across from the patient perspective. So, what do you ultimately recommend for how advanced neuroimaging should be incorporated into routine protocols?
So we actually recently changed our conventional protocols so that we're actually including DSC as part of our standard of care. We still have the advanced tumor protocol where we're able to do other perfusion sequences and spectroscopy, and we do try to reserve those for when there's a question. And the main time point in which our oncologists really are trying to distinguish between the two we found is during the 3 to 6 month period after they've completed radiation, where the patient's on adjuvant temozolomide, and it's hard to make the call of progression, but it helps them to potentially try to move them into trial therapies. And so I think that time point probably is a key time point to think about using advanced imaging techniques to help you to help the clinical team make those decisions, and also probably I think it also relies on the imaging. What changes are happening from an imaging perspective that are more questionable versus blatant and flagrant progressive changes.
Your institution is a comprehensive cancer center. Do you think these findings will be generalizable to community practices?
I think so, in the sense that I think all practices are trying to ensure efficient use of resources. And as I pointed out, there's not necessarily more reimbursement for a longer study. And so this helps institutions potentially determine what patients are the correct patients to apply the advanced brain tumor imaging protocols, or even to justify why they may need to put more resources into it. Uh, and also, maybe it helps neuro-oncologists to convince their community radiology practices to invest in this type of more advanced imaging techniques.
And to close, can you restate your study's final takeaway for our listeners?
Yes. So we found that advanced neuroimaging techniques using perfusion and spectroscopy made a significant impact in decision making for neuro-oncologists. in determining differences between treatment change versus progressive tumor. And we think that it can be a valuable tool in the appropriate setting.
Dr. Chen, thanks so much for joining us.
Thank you.